Kia ora koutou, tēnā koutou, tēnā koutou, tēnā koutou katoa. Welcome, welcome, welcome everybody to our session this morning or this afternoon here in New Zealand. It's wonderful again to see your faces, and we look forward to our next few hours together. I'm going to begin with a new greeting, which I'll explain in English first and then I'll read it in Te Reo Māori. It says, "To the esteemed of the four corners of the world, or four winds, I acknowledge you and welcome you. I am glad that you have come to join our event. And so I greet you, I greet you, I greet you." There we are. So we're all glad that we're here together. E ngā mana, e ngā hau, e whā, tēnā koutou katoa, no mai haere mai e koa ana te nākau, kua tai mai koutou, ki te whakanui I te kaupapa o te rā. It's the agenda of the day. Nō reira, I aku rangatira, tēnā koutou, tēnā koutou, tēnā koutou katoa. All right, so we're committing ourselves to taking ourselves away from all the things that have been on our minds and occupying our thoughts so far today, and we're going to carve out some space to continue to focus on different aspects of what it involves to be involved in leading and managing in public health. And we've been journeying through, over the last few weeks, different elements of that puzzle. And so today we're going to sort of round off a few more things, and one of those is the issue of behaviour change, which Dilla is going to be leading on. And it's a really interesting area, because I think if we all look at our own lives, I think we'd have to recognise that changing our behaviour is extremely difficult to be consistent if we have habits or particular actions. And so Dilla will be unpacking that and giving us some working tools to help think about behaviour change, because it's an important element when it's, whilst occurring at an individual level, as he'll point out, there are other factors that impinge on whether people change their behaviour or not. Okay, and then we're going to follow that with a session that I'll be leading on research, monitoring and evaluation, and just comparing those different elements of what we often do to think about the effectiveness of our actions and strategies and programs. And I'll give you some examples from some of the work that I've been involved in, and some other work that some of you may have also done. And again, try and provide you with some tools and frameworks that might be helpful if you're involved in, particularly in the monitoring and evaluation of programs. Also, these same tools that help you with evaluation also help you with design and thinking about measurement. So we'll kind of retread some of the material we covered in the research session weeks ago, but fundamentally it'll be thinking more about monitoring and evaluation rather than research. And then just to follow on, next week's going to be a busy week as well. We've got a session on I'm sure it will be a very, very good session that's going to be led by one of our leading public health professors and thought leaders in New Zealand and the wider Pacific region, Professor Sir Colin Tukuitonga, who's from a small Pacific island himself and has risen to become a global leader in public health. And he'll be sharing with us his thoughts and reflections. And then Put will be leading a session on public health management in disasters and other crises. And then we'll wrap up on the Thursday. As you know, you finish off the course with graduation, but before then, thinking big, stretching out, how can we apply all these things we've learned to some of the big global health issues and challenges before us? So Foot again, with Noah Bunkley, who's another public health doctor, we'll be working together on that session. So I think we've got a good day together today, and then we've got an action-packed 2 days next week, of course, wrapping things up on Thursday after the last session. Thursday will be the graduation and closing ceremony. Okay, so any questions about the program ahead of us, or we're all good to go? Thumbs up if we're all good to go. Great. All right, so Dilla, it's my pleasure to welcome Dilla to lead us on this session. Dilla, you might like to just give a bit of a refresher of intro about yourself again, and then over to you to share the screen and go for it. You're on mute, I think, for some reason, or we can't hear you. Can't hear you, Dilla. Where are you? Okay, just check your sound.
Maybe it's your phone or your...
Are you in the building, Dilla?
You can come to my room, Dila. Yeah, I will.
Yeah, we can't hear you at all,
We
I'm
can't
afraid.
hear you, Dila.
So I'm in 3054 if you want to join me there. Or I've got give you the headset. You need a quick solution. While you're doing that and sorting that out, you could go out of Zoom and come back in and just try and see if that resets the microphone setting. If you exit Zoom and come back in, yeah, just try that. Sorry about that technical issue. I can tell you a little bit about Dilla while he's away. So he's, I think he already introduced himself, but he's got an undergraduate training in neuroscience, a master's in public health, and he's just submitted his PhD in public health. And he has, he's from Saudi Arabia, but his parents hail from Malaysia. Okay. So, yep. So he's joining Put in that room, I think. And his work in his PhD focused a lot on behavior change and designing an intervention for smoking cessation using a model to help design behavior change interventions, which he will share with you because he's become quite expert in it. Foot, is Dilla joining you there, or? Oh, here he is. Just admit him. Dilla, are you there?
Hello, everyone. Yes, I'm here.
Loud and clear.
Okay,
We just need to see you. Yes, perfect.
wait.
Right.
Okay, sorry about that.
That's okay. I just told them a little bit about you while you were away.
Okay, that's good.
All good. All
It's
good
that
though.
you know.
And Juanita will make you co-host first so we can share your screen. Dila.
Okay. All right.
Just to share screen.
We'll share the screen.
Yep.
Sorry. I think my slides went.
Oh.
My slides are not.
Just go into PowerPoint and bring them up again as the front thing, and then they'll appear on the options to drop into the panel when you click picked. All good.
Can you see the screen?
Absolutely.
Yeah.
100%.
That's great.
You just drop back to, you just need to click back onto full screen icon down the bottom again. That little.
Oh my God. This is so confusing.
No, you're right. Don't take it off the screen share. Just click on the little full screen icon at the bottom of the view.
It's this one here, right?
Yeah, it's that little like a screen you put up for showing movies at home.
Yeah, this is the one that I want
next to the book one.
I can't do it now. I think I have to go out and in again. I don't know.
Well, worst case scenario. You had it before. It was just showing before, and then it dropped back to.
Okay.
That's it. Just be patient, and it will. There, perfect.
Okay.
All good.
If I wanna go into notes,
You possibly can't. I don't know what you've set up there, Dilla. So I just know the content of your slides.
Okay.
The advance is on the left-hand side at the bottom of the screen.
Okay.
Backward and forward buttons you can click on.
Okay, sorry. Food, can I use your laptop? Is that okay?
Sure.
Sorry guys. Oh my God, this is a mess, but That's why I wanted to use 2 screens, but it didn't allow me.
Oh, I see.
You will not.
Yes. Yeah. Sorry for that. Oh my God.
Okay. We could just go around and just check in with our colleagues from the Philippines and just ask if everybody's doing okay
Oh.
while we're waiting. Okay. Any update on the situation post super hurricane and
Yeah.
Vietnam as well?
Yeah, some areas are still some areas are still I think some still don't have power, but maybe
Right.
our colleagues from the Philippines here would have more
Put the slide
updates
here.
because I think
Right.
their areas were devastated by
No,
the
I'll put the slides here. But
by
I'm just
the
gonna
typhoon before the super typhoon.
Right.
So
Yeah.
anybody who'd like to
can
hope
I
we're
put this
all
here?
okay
Because I
now
just
and
wanna read the notes
Just
here. Just see the
Could you
notes.
take your volume off, Dilla, if you could just click
Sorry.
on audio off. That's it. Still a few people coming in. Oh, here we are. Thanks for asking. Internet's still low here with no electricity yet in some areas. Wow. Okay. So you've still got access to Wi-Fi, and that's great. And interconnection is poor. Okay. All right. Yeah, no, that's amazing. Gosh, poor things. It's one thing after another, isn't it?
yeah, but it's amazing that our scholars are really exerting effort to join
Hello,
the
everyone.
class.
It's incredible. That looks good. Dilla?
Looks good? Okay. Oh my God.
Okay.
Finally.
Okay.
Okay. Thank you so much for
Thank you. Thanks for the technical support, Food.
Thank you for the technical support. All right, everyone. Thank you so much again for your patience, and I am very happy to be here with you. So yes, because we might run out of time, so I'm just gonna
That's okay.
go into it. So today I'm gonna talk briefly about behavior change in public health, and as Chris have already introduced me, so I don't have to introduce myself. So this is a little bit of what we're gonna talk about. First, what is behavior change, and specifically, what is behavior change in the field of public health? And then we're going to talk a little bit about the importance of behavior change science in public health. And then after that, we're going to dig deep a little bit into theories of behavior change. And I know for some or a lot of people, theories are boring. We don't want to hear about them, but I promise you that behavior change theories are interesting. And then after that, we will talk about briefly just about behavior change science in relation to the Ottawa Charter actions, if you remember them from previous slides. And then after that, we will talk a little bit about the application of behavior change science to design and evaluate public health interventions and programs. So just to explain what is behavior change in public health, it involves applying behavior science or insight to identify and modify the psychological, physical, social, and environmental factors that influence or shape health-related behaviors at individual, community, and population levels, with the goal of preventing disease and improving overall well-being. Behavioral science is a multidisciplinary approach, and it can help understand the factors related to people's health, why they do what they do, for example. Thereby, it informs the design of more effective interventions, policies, programs, and services, and so on. The behavioral change model within health promotion is a preventive approach, which focuses on lifestyle behaviors influencing health, and it seeks to persuade, if you will, individuals to adopt a healthy lifestyle behaviors. For example, healthy diet, eating healthy, physical activity, quitting smoking, and so on. The World Health Organization adopted the first ever global behavioral science for better health resolution and this is recently on May 2023. If you're interested in knowing more about these, I've provided the link below. And then we have the example of Malaysia. Malaysia recently, in September, which was 2 months ago, they adopted the WHO initiative for behavioral science. So the aim was integrating behavioral science into health policy, planning, and service delivery. It also sought to apply behavioral science into academia and research, and designing people-centered or patient-centered, you will, and behaviorally informed policies and programs. The aim was also to translate behavioral science into actionable strategies for policymakers, practitioners, and partners across Malaysia's health system. And I like this quote by Dr. Rabindra, the WHO representative to Malaysia, Brunei, and Singapore, who said behavioral science helps us understand not just what people do, but why they do it. And I think the why they do it is very important. This blueprint is a step forward in shaping systems and policies that are practical, inclusive, and lasting. And throughout the lecture, we will get to know how it can be practical, inclusive, and lasting. This is a video that I will play. It's only 3 minutes, showing showing the initiative in Malaysia, the establishment of initiative. Can everybody see? Sorry.
Yep.
Yeah. Okay.
Just the sound may be an issue.
Okay.
It's just, oh, here we go.
For the official launch of Malaysia's first national blueprint for behavioral insights in health, and NBR.
I think we need to look at how we can use behavioral interventions to help guide people
to grow and ensuring BI become a core element of Malaysia's public health practices.
Actionable conclusion about human behavior that's derived from multidisciplinary behavioral sciences in health.
I would like to suggest that to all the other academians to focus more and to apply behavior insight into their research project.
Given we're a multicultural country, so behavioral insights will help us develop solutions centered around different cultural backgrounds.
The blueprint is just the first step of a long journey.
Oh, sorry. Is it working?
It's just a little bit jerky, but it's pretty much there, I think.
In order for us to normalize or to mainstream behavior sciences.
Many of today's health challenges, whether it's increasing vaccination rates, preventing chronic diseases, responding to emergencies, addressing mental health challenges, are deeply influenced by human behaviors. Behavioral science is now recognized as a core pillar of public health. Today, by launching this national blueprint for behavioral insights in health, Malaysia is not only fulfilling a global commitment, but also setting a benchmark for the region.
This behavioral insight for health would actually be one of the policies that are driving the community to actually make the change that we want to see.
We have to navigate the people to choose the right way to live your life healthily. We can do this. All the ministries also can do this.
Health is not just built in hospital alone. It is built in homes, in schools, workplace, and communities. Real change happens when healthier option is made easier, more attractive, and more convenient. It must take the approach of a whole, not just a whole of government, but a whole of nation approach. Collaboration and advocacy, strengthening partnership, and building a community of practice, community of practitioners, or community of practice across sectors. Right foot and then a shake. Right. 1, 2, 3.
All right, that was a wonderful video. Sorry, I just want to change the slide. How do I go to the other slide?
Just go to the next slide at the bottom left-hand side of your screen.
Bottom, yeah.
Yeah, just or can you click just advance to the next?
This one, right?
Yeah, it should be right at the bottom by in front of audio. You should be able to pick up a couple of buttons that you can move. Unless somebody else has got the expertise to.
I can see it, but
yeah.
I can't see it.
Okay. Can you scroll down on your laptop to the next? That's
Yes.
it.
Okay.
Perfect.
Great. So when we saw the video, everyone, they were talking about multicultural. They were talking about school, workplaces, where you live. They were talking about making healthier options available and attractive and more convenient. And these were all keywords that we have been through in previous lectures. And this gives me an indication of how important behavioral science to be integrated in public health. So why is behavior change important in public health? One is, of course, to prevent disease. Human behaviors are complex and they rarely occur in isolation. So they are shaped, the human behaviors are shaped by the dynamic interaction between personal, social, and environmental factors. The second important point is to promote health and well-being. Many major health issues, for example, cardiovascular diseases, cancer, obesity, diabetes, and so on, are caused by modifiable behaviors. Modifiable behaviors such as smoking, overeating, binge drinking, unhealthy eating, physical inactivity, and substance use. These are all changeable behaviors. Another important point is to address the environmental and social determinants to health. And also, the last important point is that behavior change science will help us design effective interventions in public policies. In addition, behavioral insights behavior change theories or science helps us understand these complex behavior. And by applying these theories that we're going to talk about and gaining insights into these behaviors, we can design strategies that support disease prevention and health promotion. Behavioral insights also play a critical role in informing effective public policies. For example, understanding driving behavior can inform road safety initiatives. Another example is understanding vaccine hesitancy to improve vaccine uptake and immunization. So changing one's behavior in isolation is rarely enough because people's actions and behavior are strongly influenced by the systems and contexts in which they live in, but also their families, the societies, the communities, the workplaces, and the environments. So understanding how and why people act the way they do and how their actions are shaped by their surroundings can help us design interventions that are relevant, appropriate, and effective. Think of smoking cessation, for example. I want you to think of smoking cessation and think about the reasons for smoking. Are the reasons for smoking similar for youth, pregnant women, migrant, and health professionals? So consider the enablers and barriers to smoking cessation in various cultural, religious, social contexts. For example, religious versus secular settings. Are they the same enablers and barriers? Understanding those through behavioral science will help us address the environmental, social, and determinants of health and design effective interventions and public policies. Chris, can you see? I changed the slides. Hello?
Can you try to just move your cursor, Dila?
Yeah.
So in your computer, you can use the arrows. That should be easier for you to move your slides.
Okay.
So we could see that.
Yeah, I don't know. Can you see the slide? Because I can't see it in
No,
my...
it's blank now. We
blank.
could see a blank one, but you could just click it. Maybe you have animated some of the components.
No.
So just try to click it again.
If I click it, it changes to the
Okay.
I don't know what's happening here, honestly.
Would you like me to just share?
Yes.
I have your slides, and then
Can you
can
please?
also
Yeah, I don't know what's happening.
let me just grab your slides first from Candace.
Thank you so much. Okay.
While we're just waiting for that to happen, just on the chat, it was just acknowledging that the 6 pilots from the Philippines Air Force went to Myanmar to help in earthquake areas for search and rescue, and were killed, and there was just an acknowledgement for their contribution and the loss of those people. Yeah, a lot of hardship and challenge for the countries in the region. So thank you for sharing that, Phone and Nino.
Okay, I will try to share your screen, although it would be on like PDF mode, but they could see it if that's okay. I'll just try and do that.
Yep. Need to unmute now, Dilla.
Thank you, Gay.
Yep.
Is it shared now?
Let me do that.
Okay.
Okay, could you see that?
It's come up now. Yes.
Yep.
Yes.
So is this the slide that you want?
Yes. Yes.
Okay.
Thank you. Thank you, Gay.
Okay.
So as you can see here in the slide, effective interventions intervene at many levels and simultaneously and consistently. Evidence suggests that for interventions to be effective, they should be grounded in behavioral theories. It could be 1 or 2 or more. And behavioral science provides a framework for understanding behavior at these multiple levels, the level of individual, community, and population. Let's take, for example, vaccination. Vaccination is a key public health intervention for preventing infectious diseases such as influenza and COVID-19. However, vaccine hesitancy can hinder vaccination uptake rates. But by understanding why people are hesitant to take the vaccine, why they delay or do not want to take vaccine, we can intervene at different levels. At the population level, for example, we can focus on increasing vaccination sites and reducing waiting time to obtain a vaccination. At the community level, initiatives may focus on normalizing vaccination and bringing vaccination services to community locations. At the individual level, we could target individuals through education and reminder systems that can help increase vaccination uptake. The next slide.
Next slide.
Sorry, Gay. Yes. The next slide, we'll talk briefly about the behavioral theories. These are some of the behavioral theories that exist. Some of them are at the individual level, some of them are at the interpersonal level, and some of them are at the community level. So there are numerous theories underpinning behavioral science, and each operating at different levels of influence. Some focus on the individual, others focus on the relationship between one another, and others focus on the community level. On the individual level, as you can see in the slide, there is the health belief model, which is a very old framework. It's a framework for understanding preventive health behaviors. The health belief model, I will talk about these briefly. It consists of 6 cognitive constructs that they believe influence behavior. So one is perceived susceptibility. Two is perceived severity. Three is perceived benefits. Four, perceived barriers. Five, self-efficacy. And the sixth construct is cues to action. For example, perceived susceptibility refers to how likely a person believes they are going to be or to get a disease or a negative experience or a bad outcome. For example, in COVID-19, in the case of COVID-19, the individual may believe that they are susceptible to contracting COVID-19 when in crowded public places during the pandemic. So that will influence his or her behavior. Am I going out? Am I not going out? Perceived severity refers to how serious a disease or a health condition is and what might happen if they don't take action. For example, people often consider both the medical and social consequences when assessing the severity of illness. For example, I might miss work. I might infect my family, loved ones, or I might be hospitalized. For example, during COVID-19 pandemic, people responded differently depending on how severe they perceived that illness to be. For example, people who perceived COVID-19 as a serious illness and that they might be hospitalized were more likely to engage in behaviors to prevent the disease from spreading and vice versa. Perceived benefits also refers to the degree to which a person believes that a specific action will help reduce the risk of a health problem. For example, wearing a mask or getting vaccinated is more likely if someone believes that these measures will genuinely protect them from infection. So these are some examples of the six constructs of the health belief model. And then we have the theory of planned behavior. This theory also is an old theory. It proposes that behaviors are influenced or predicted by intentions to engage in that behavior. So intentions here, you could say the key word, which are determined by three constructs: attitudes, subjective norms, and perceived behavioral control. Let's take attitudes, for example. A person's attitudes towards a specific behavior, that is what they mean by attitudes. How positively or negatively a person feels about performing a behavior. For example, a person who believes that smoking causes them to cough in the morning, that's a negative attitude towards smoking. And that quitting smoking will improve their health, that is a positive attitude towards quitting. This person is more likely to view quitting as a desirable behavior and take action to stop smoking. And changing an individual's attitude could be achieved by modifying the evaluation of an existing salient belief about smoking or quitting. For example, increasing the salience of an existing negative belief. You probably know that smoking is harmful, but you may not realize that it can increase the risk of heart disease and lung cancer. That is an example of increasing the salience of an existing negative belief and therefore changing individuals' attitudes toward that behavior. Or decrease the salience of an existing positive belief. You may think smoking helps you relax, but there are healthier and better ways to manage stress. When we talk about now, the other construct is subjective norms within the theory of planned behavior. The perceived subjective norms refer to the perceived social approval or disapproval of the behavior from peers or from family or the community. What people think about the behavior, that's what we mean. For example, in some cultures, smoking is stigmatized among women more than men, which can reinforce quitting, right? Can reinforce quitting or staying non-smoking among women, but it reinforces smoking, make people smoke because it is not stigmatized or denormalized among men. So smoking is, for example, in some cultures, smoking is associated with masculinity among men, which encourages smoking. These are examples of subjective norms. Perceived behavioral control is another construct of the theory of planned behavior. What we mean here is the person's belief about how easy or difficult it is to perform the behavior. And this is what we call self-efficacy. For example, someone might say, I believe I can quit smoking and manage cravings, for example, using medications. That is perceived behavioral control. I can take control of my smoking. And this person is more likely to take action. On the interpersonal or societal level, I will go into the stages of behavioral, I will go to the trans-theoretical model before jumping to the interpersonal model of behavior change. The stages of change or trans-theoretical model is an interesting one. It says or suggests that health behavior change involves progress through multiple or through 6 or 5 stages. The first one is pre-contemplation, and then contemplation, and then preparation, and then action, taking action, and then maintaining that change. Okay? So pre-contemplation, this stage is when someone is not ready. It is when the individual has no intention to change their behavior in the near future, usually within the next 6 months. People in this stage are often unaware that their behavior is problematic or there is a problem in what they do. Being uninformed or underinformed about the consequences of behavior may cause a person to be in this pre-contemplation stage. For example, someone may not be aware of the serious health issues related to smoking. In turn, they do not intend to quit smoking, and some people may not see smoking as a problem. So a goal for intervention here is to increase awareness of the risk of smoking and the benefits of quitting. Increasing awareness and the risk of increasing awareness of the health risk of smoking and the benefits of quitting might move that individual to the contemplation stage in which they think about it now. This stage is when people intend to change in the next 6 months or few months. They are more aware now that their behavior is problematic. This stage involves decisional balance. That is, they assess the pros and cons, the negatives and the positives of changing the behavior. For example, someone who smokes becomes more aware that smoking is harmful. It causes cancer and respiratory illness. So they think, and they also think of the benefits of quitting and the costs of continuing to smoke. So here, the goal of an intervention might be to strengthen motivation further and increase confidence that quitting is possible, which can take the individual to the preparation stage. Now they are getting ready. They were not thinking about it. Now they're thinking about it. Now they are in this third stage, they're getting ready. So the person here intends to quit soon, usually within the next few months, and may have already taken small steps towards behavior change. They decided to change their behavior and have a plan. For example, someone has decided now that I want to quit smoking and sought professional support. In this stage, an intervention might aim to plan coping strategies. A person might tell family or friends about their plan to quit smoking. Therefore, please support me. I am preparing. And then a person moves to the action stage, and that is doing it. This stage in which people have made specific modifications to change their problematic behaviors or acquiring new healthy behaviors. This stage is characterized by observable changes in lifestyle. For example, someone is using nicotine patches, someone deliberately and actively avoiding people who smoke in order for him to quit smoking. He's spending time, or he or she is spending time with people who do not smoke. And for example, doing sports as an alternative activity. That is the action stage. And an intervention goal in this stage might provide practical support, encouragement to persevere, to maintain, which then takes the person to the maintenance stage, in which people change their behavior and sustain the behavior change for at least 6 months. So people in this stage now are aware of the risks, and they are knowledgeable of relapse, and they are also prepared and planning on how to prevent relapse. The goal of this intervention, the goal of an intervention in this stage might be, for example, just to sustain a healthy lifestyle, Sorry, can we go to the, no, so.
Interpersonal?
Sorry. Yeah, sorry, Gay, I'm annoying you with going back and forth. So on the interpersonal level, we have here the social learning theory. The social learning theory has been applied in educational and clinical psychology settings. It suggests that behavior is learned by observing others, emphasizing the role of modeling, imitation, and reinforcement. It means we watch what others do and adjust our behaviors accordingly. So this theory of behavior can help us understand how our environment and the people around us shape our behavior. Think of smoking, for example, and how it is normalized or denormalized among a group of people. On the community level, the diffusion of innovation theory, as you can see here, it refers to the process that occurs as people adopt a new idea, practice, product, or behavior. That's the overall definition, or the overall definition of this description of this theory. So over time, the idea or the innovative idea or product or behavior becomes diffused amongst the community or population, hence the diffusion in the name, this theory consists of 5 key elements: the innovation, the adopters, the communication channels, time, and social system. These are elements of this theory. For example, the innovation could be vapes or e-cigarettes. And then the adopters are the individuals adopting this behavior, or the businesses adopting this behavior. The communication channels could be social media or peer networks or mass media promoting vapes. For time refers to the early experiments of vaping. From early experiments of vaping to wide use among the youth population. And then 5, the social system refers to the cultural norms and peer influence and public health messages that shape vaping diffusion. These are briefly some of the theories in regard to behavior change. Can we go to the other slide? Sorry, yes. One prominent theory is the behavior change wheel, which was developed by Susan Michie, or some people say Susan Mickey, and her colleagues. This framework consists of 3 layers, as you can see here. Okay? At the center of this layer is the behavior system, or the COMBI model, which involves 3 essential conditions, and that is capability, motivation or opportunity, C, capability, O, opportunity, and M, motivation. Those elements influence behavior. This says that an individual's behavior is shaped or influenced by the interaction of their capability, opportunity, and motivation. So what do we mean by those? Capability, can we go to this next one? Sorry, okay. Capability refers to whether we have the knowledge and skills and ability required to perform the behavior. These are internal factors, and it could be physical or psychological capability. Physical capability refers to our skills or physical skills, our strength and stamina. Psychological capability refers to our knowledge and interpersonal skills. Did you have any question, Chris? Or did you want to say?
No.
Okay. The second element is opportunity, which refers to the external factor now. The external factors that enable or encourage behavior. And it also consists of physical and social opportunities. Physical opportunity refers to the environment, to time, to resources that enable engagement in the behavior. Social opportunity refers to the social factors, for example, the cultural settings, the social norms, cues, and social expectations that may reinforce or prevent engagement in the behavior. And lastly, motivation. Motivation refers to the internal processes that drive the behavior, and it consists of two components, either reflective motivation or automatic motivation. What we mean by reflective motivation, these are the intentions, the beliefs, the plans, and the evaluations that guide one's actions. For example, we talked about decisional balance that could fall into reflective motivation. However, automatic motivation refers to our emotional reactions, our habits, and our impulses that drive our behavior. For example, I've seen a lot of studies when they talk about automatic motivation, addiction to smoking or to substance use. These addiction could fall into automatic motivation, especially when we talk about compulsive behaviors within the addiction realm. Can you go down, Gay? Sorry. Okay. In the middle layer, okay, we have the intervention functions. These refer to the activities aimed at changing behavior. And we have 9 functions here. For example, education. I'll just take a few examples. Education refers to imparting knowledge and developing understanding, increasing awareness. And then we also have training, which some people can say, okay, education is training, but training here focuses on skills development. So my take is that education refers to the psychological capability. However, training might relate to the physical capability. Can we go a little bit down? Yes. And then we have these policies. For example, designing, we have 1, 2, 3, 4, 5, 6, 7 policies of intervention. The policies are the actions on the part of the responsible authorities that enable or support interventions. For example, making or changing laws, delivering services, establishing guidelines, and so on. Okay, yes, can you? However, we've talked about these behavioral theories, some controversy regarding the COMBI model. You can read about them in the link that I provided. Some scholars, such as Jane Ogden, she argued that using the COMBI model might oversimplify the complexity and natural variability of human behavior. That is, not everyone behaves the same. So systemizing behavior change by the behavior change wheel or the combi model might limit creativity, and it might make behavior rigid, which is not the case, because behavior is not the same among people. For example, I might give the same intervention to two persons. One might change and one might not change. Can we go to the next one, please? Okay. These are some.
Okay.
Yes, yes. These are some of the examples of intervention functions in relation to smoking cessation. For example, education, providing information about the benefits of quitting and the risk of smoking. This is one intervention function. And interventions can have more than one function. For example, education, but at the same time, for example, training, which could mean teaching coping skills to manage cravings and withdrawal symptoms. It could also include environmental restructuring. That is, for example, on a population level, removing ashtrays from public spaces. And this is one picture that I used to see a lot in the streets back home in Saudi Arabia, but now they're removed. I think in Auckland as well, we don't have ashtrays in public spaces. But even in the individual level, individuals might be encouraged to remove ashtrays from their houses just to help them not to smoke. And then in the next slide, Gay, please. We have the intervention or policies, for example, also in relation to smoking cessation. A policy might be communication and marketing, and that involves nationwide anti-smoking campaigns. It could be regulating tobacco advertising, promotion, and sponsorship. You can see the pictures here on the right. Michael Schumacher, is celebrating his victory with Marlboro on his chest, but now these are not allowed anymore, right? So I'm aware that I might go over time, so I'll be quick. Now I want to talk about...
It's okay. Your time's fine, Dilla. You've got plenty of time. Yep.
Okay, that's great. I would like to talk about the Ottawa Charter actions in relation to the combi model, or in relation to behavior change. So the importance of behavior change in informing and guiding the actions outlined in the Ottawa Charter. We will focus on developing personal skills, creating supportive environment, and reorienting health services. If we go to the next slide. Okay, it says here developing personal skills, and these are taken from the WHO website in relation to this action. It says supporting personal and social development by providing information, education for health, and enhancing life skills. Okay, so the focus is on personal and social development, okay, which by providing information, education, and so on, which aligns with the capability element of the combi model that we talked about just now. Therefore, understanding capability from behavioral perspectives can inform strategies and policies that aim to achieve this action of the Ottawa Charter. It talks here about supporting people to take control over their own health and environment and enabling them to make healthy choices, which what the leaders said when we saw the videos, right? One of the leaders says, we want to make healthy choices attractive. And he also said it should be facilitated in school, home, work, and community settings. Okay, moving on. So developing personal skills here by increasing awareness and knowledge among the target behavior. And this relates to the psychological capability. And what relates to the physical capability is providing training on how to perform the behavior correctly and safely among the target groups. For example, how to use nicotine patches, okay? And the important message here as well is that education and training should be relevant and appropriate for the target groups. All right. And this is possible, or behavioral insights and behavioral understanding can help us tailor education and training to be relevant to the target group. Okay, we move on, please. Gay to creating a supportive environment. So creating supportive environments in the Ottawa Charter, it focuses on the built in social or societal environments where we live, work, and play should be healthy, should be supportive environments that encourage healthy choices. And this, in behavioral perspectives, it might relate to the opportunity element of the COMBI model. For example, the next slide, creating supportive environment may increase both the physical and social opportunities to engage in the behavior. And when we think about creating supportive environment, two important notes here is to we consider, or we should consider, consulting with community members to identify the most effective ways to utilize national resources and materials within the local context, and also collaborate with health providers, government agencies, and community organizations. The next slide, reorient health services. This action focuses on expanding health services to meet the cultural and social needs of individuals in communities. And behavior change research or science can help us understand the underlying cultural and social factors that influence behavior. It can also provide insights into the specific health needs of individuals. For example, I'll give an example for reorienting health services. Faith groups, research suggests, they trust health organizations, sometimes more than mainstream health services, which led to the implementation of health programs in churches or mosques. And we have seen many church-based health programs and recently mosque-based health programs being implemented as a result of understanding behaviors. All right. Yeah, sorry, can you go the previous one? Okay, yes, sorry. Okay, these are the steps for developing behavior interventions. These are not the only steps, but these are from Mickey and her colleagues, the steps for developing behavioral interventions. We'll go through it just briefly. So the first step is to understand the behavior. Defining what, in this stage, we want to define the problem in behavioral terms. What is the problem? It could be physical inactivity. It could be smoking, for example. And then we select the target behavior. The target behavior could be the whole population, or could be a specific group within that population. And then we specify the target behavior, okay? And then we identify what needs to be changed, okay? And I will give you examples of these. The second stage is to identify intervention options. And these include identify intervention functions, as we discussed, and identify policy category or categories. And then the last stage is to identify content and delivery options. Here, we identify the behavior change techniques. Now, what do we mean by behavior change techniques? Behavior change techniques are specific and the active components or ingredients, as they say, of the intervention that are designed to alter behavior. Okay, so for example, Chris always uses this example. like baking a cake, right? So baking a cake, you need to understand you need to know the ingredients, all right? So for example, you select the cake. Is it going to be a strawberry cake, chocolate cake, and so on? And then we need to specify later on the ingredient, the active ingredients. Now, what's important here is that behavior science can inform which BCT or which behavior change technique that are most effective. Let's go again to the cake example. For example, a strawberry cake, you will have different recipes with different ingredients, right? But there are ingredients, okay, that are must. So you could say these are the effective ones. And there are ingredients that if you take some, it might not change a lot. And if you put them, they might not change a lot. So that is why it is important to use behavioral science to know what behavior change technique is most effective. And also behavior science can help tailor behavior change techniques based on the characteristics of the audience. For example, social support, we know what social support is. Social support is a behavioral change technique. But social support can be defined differently, can be perceived differently based on culture, ethnicity, or religion. Similarly, providing information, okay, and knowledge is a behavior change technique. And to provide meaningful information about, for example, smoking cessation, we may want to tailor the context based on specific values or languages or culture or ethnicity or religion. And then we identify the last step of stage 3 is to identify the mode of delivery. Would that be through SMS or would that be through brief intervention or printed materials and so on? Can we go to the next one? Okay. Now I'll give you an example of Saudi Arabia because I am from Saudi Arabia and how understanding behavior change and following the steps can inform public health initiatives. So we had a problem. The problem was physical inactivity and sedentary lifestyle. These are public health concerns in Saudi Arabia. So we identified the problem. Now we identified the target behavior, which is increasing physical activity and limiting screen time, for example. And then the next step, we want to specify the target behavior. Who, that is the general population, including male and female of all ages. What are they going to do? Increase physical activity. The aim is to do physical activity 150 minutes or more per day. And also decrease screen time. When? Early morning or evening, because those are the most appropriate time. Where household, in the neighborhood, in workplace, in recreational centers, that is where. And then we want to understand what needs to be changed. Within this step, we conduct what we call behavioral diagnosis. And these can be done through focus groups, individual interviews, questionnaires, observations, and even literature review, like systematic reviews of scoping reviews. So we analyze behavior using behavior theories, such as the COM model, for example, here. And I use the COM model in this little example. If we go to the next slide, okay. Okay, this is evidence on physical education in Saudi Arabia. Okay, as we can see, the evidence informs us that, okay, this is the percentage of physical activity, okay? Male usually are more physically active than female. See, males, females, practitioners, that means practice physical activity, male are more than female. However, if we go to the next slide, for example. Yeah. we also see here the same research sought to understand the reasons for not practicing physical activity. And they said that, okay, the first one is that they are unwilling to do physical activity. And we can say as well here, female more than male. And then the second reason was lack of time. The third reason lack of enough facilities in the neighborhood or district. Another reason is injury or impairment. And this study differentiated between Saudi and non-Saudi, female and female, but this is just an example. So I just took an example of Saudi male and female, and we can see that the literature informs us that the female's behavior is different than male. They are more physically inactive than the male. But then it also informs us that of the reasons for not being physically active. So if we go to the next slide, understanding this was a cross-sectional study, all right? So when we talk about the unwillingness to practice physical activity, this can relate to the reflective motivation. For example, it could be that people lack, or they are not aware of the benefits or the long-term benefits of physical activity. They might have low self-esteem. For example, one might say, I'm not good at sports, or I'm shy to do sports. It also could relate to the automatic motivation. For example, someone does not enjoy physical activity. That is why he or she is unwilling to do it. Or they had negative experience with exercise. For example, pain or embarrassment. So in this reason, this reason relates to motivation. The other reason, lack of time, could relate to opportunity, as we talk. I don't have the opportunity to do physical activity. Same as the lack of facilities. I don't have the opportunities outside the house or inside the house or at my workplace to do physical activity. And then injury or impairment can relate to the physical capability to engage in physical activity. However, these quotes on the right side is my take, or what I conclude is that this was a cross-sectional study. What we want to know as behavioral scientists is we want to understand more of why. So unwillingness to practice physical activity. Why not willing to be physically active? What are the barriers and possible motivators for physical activity? Understanding this will help me design and develop public health interventions. And the second one, they said lack of enough time. So why do they not have time? And what we want to understand why they don't have time. Is it because of work, or is it because of taking care of children? So that's why I don't have time. And we want to understand what might support. Okay, how can we help to give you enough time? For example, bring physical activity initiatives at the workplace if I don't have time outside the work. Lack of enough facilities. Or injury or impairment. What can be done to help people with disabilities? For example, behavioral diagnosis in this field, regarding injury or impairment, can ask or can interview people with disability, how your disability prevents you from physical activity, and what specific needs you need to become more physically active. So these are just some thoughts. And then after that, the Saudi Arabian government as a whole, they initiated physical activity campaigns and programs that involve multi-sectors, local municipalities, the Ministry of Health, the Ministry of Education, and the Committee of Sports and the Committee of Olympics and Sports. If we go down here, sorry, okay, yes. So for example, you can see here the street conditions in some neighborhoods of Saudi Arabia are barriers to physical activity. It doesn't say in the literature. However, understanding behavior, doing behavior diagnosis, we can understand. Okay, so the street conditions in some neighborhoods of Saudi Arabia, as you can see, they are unsafe. They really don't encourage you to do any physical activity. They're not appropriate to go outside and do physical activity. Okay, if you go to the next slide, you can see how local municipalities implemented infrastructure projects to develop and improve walking and cycling paths. These are now the conditions of many of the streets in Saudi Arabia. You can see the development. And then another slide. These are also some of the initiatives. Okay, so for example, you can some of them are in Arabic, I know, but like you can see here, they initiated a marathon, a community-based marathon for everyone to take part, including people with disability. And these marathons happen in major cities in Saudi Arabia, initiated by the Sports Ministry and Ministry of Health. And also the Ministry of Health started raising awareness. For example, on this one, it says the appropriate shoes. Which shoes are appropriate for walking, appropriate for running, appropriate for playing football? These are all part of raising awareness or education. And then another initiative is the mobile app initiative. So this is at the individual level, the mobile app. I was really shocked to know about this. I didn't know about this, but what I read is that the Ministry of Health are encouraging people to walk, and the more you walk, you can actually raise money up to 18 Saudi Riyal per day. So if you are physically active, you do your walk, which is I think 10,000 steps per day, you can accumulate and save up to 18 Riyal per day, and then a month you will have money, and then you can spend that money through the app in multiple stores that are in collaboration with this initiative. So these are some of the initiatives from multiple sectors and informed by understanding the behavior. Okay, in summary, we just talked about behavior change and how it is integral and critical to public health. And we talked a little bit about behavior change theories, and that effective interventions should be underpinned by behavior change theories. And these theories provide a framework for researchers, professionals, and policymakers as well for designing and evaluating public health interventions, programs, and policies. I think that's all for me. I think I finished on time, luckily, with all the time I wasted in the technical issues. But yeah, I think Chris,
That's
will
great.
see if people have questions.
Yeah,
we can
yeah,
answer.
we've got some comments in the chat which are quite good, and some jokes and comments. One says comfortable shoes is a motivating factor, so that's true, isn't it? And I was thinking of, in Saudi Arabia and many other countries where you folks are from, it's really, really hot between the early morning and humid as well. And so it's really hard if you're doing physical activity. So shopping malls, I've seen when I was in the Middle East, I found people walking in groups of women, particularly walking in shopping malls, finding an air-conditioned space where you can do physical activity, and that's another setting that could work in a very hot, humid climate. Yeah, get the government to pay for the running shoes or walking shoes. That's a good point. So someone's dropped the links on how New Zealand applies behaviour change approach on smoking cessation. We can see if we can find some material on that for New Zealand. What sort of studies would you conduct to explore the reasons behind the barriers? Maybe Dilla, you could think about that because you've actually done these sort of studies.
Yeah. So the sort of studies, I would say, qualitative studies.
Yep.
They give more insights, provide more insights about the lived experiences more than cross-sectional. So qualitative studies are, I think they are great because they give you that insight. And here comes the importance of knowing what to ask, what questions to ask, and who to target, for example. So what was the question, Chris? How can we understand the barriers?
Just what sort of studies?
Yeah.
What sort of studies would you do to help understand what the barriers are and the reasons behind the barriers? In fact,
yes, there is. Yeah. So as for example, when we were on the slides of the reasons for physical inactivity in Saudi Arabia. So the literature gives us these reasons, unwillingness. But me as a researcher or as a policymaker, I want to know what make you unwilling. So these are actually I would say, fundamental barriers. Is it because, like we said, like for example, I was amazed to know that people might be ashamed of doing exercise in public or even in gyms. They have negative experiences, for example. So knowing these behaviors, we can understand. Or for example, in the case of Saudi Arabia as well, I forgot to mention this, but the issue, or not the issue, but the topic of male and female. So I want to understand why female are physically inactive, and that through focus groups with women or through individual interviews with women, I can understand, okay, maybe it is because in our culture, women are not supposed to go out. They're most likely at home. So that's why they don't have. And women alone gym are not rampant in Saudi Arabia. So understand, yeah. So, but they are starting to increase now. You see, they're starting to increase now. And that was all from understanding the perspectives of women and what barriers and challenges do they have. So yeah, I think through qualitative studies, we can dig deep into the barriers. Yeah.
Yeah, I think that's a good answer. They can be, cross-sectional surveys. If you ask the right questions, you can gain some insights, but it's quite superficial. It might help you identify the most common factors that people identify themselves. But then if you want to understand the why and the how, you really have to dig deeper, and that's where qualitative research often fleshes things out and gives us. So I think, a combination of the two, often a survey first, and then you might dig deeper with some qualitative research. So there's a question here from Han Nguyen in Vietnam. Thank you for an interesting presentation, Dilla. And Dilla, she didn't mention any of the technical difficulties you experienced, so it's all good. So the content came through. I want to ask more questions about, in your experience, which model, health belief model or the TPB model, better predicts the theory of planned behavior. That's the TPB is the theory of planned behavior, better predicts real world health behaviors. And so that's the first part. The second part is when you're designing public health interventions, which one can we apply as the best theoretical framework, or should we kind of combine them?
So I think in my humble experience, I'm an advocate of the COMBI model because I've used that in my Master's of Public Health research and also in my PhD research. The COMBI, the behavior change wheel and COMBI model is actually the way that they synthesize that is through a systematic review of I think 19 behavior change theories, including the health belief model, I think, and the TBM. So I would say, I don't know which one better predicts real world, because the HBM is about perceived severity and perceived perceived benefits and cues, and TPB is about intentions, but also self-efficacy. So I can't give you an answer, and I don't think there is an answer which one is best. But from my experience, I find the COMBI model, the behavior change wheel, is very comprehensive. It reflects real world health behavior, and it gives a reflection of the outside world and internal processes, external factors, and internal factors. I hope that answers your question.
Yeah, I guess, can I just add a bit of background? The COMBI model was developed because all these other theories were kind of not as strongly predictive of outcomes as they were hoping. So even like the trans-theoretical model breaks down in some situations where people can just suddenly change from pre-contemplation to action. And there's a little arrow in that model where they can just leap over all the, contemplation, etc., all the other steps. So, so for example, sometimes people say, I'm going to quit smoking tomorrow, and they do, and they miss all the, all those steps in between. So, and also addiction is another factor in behavior change that's sometimes not included very explicitly. And I think the health belief model, etc., often fails to include the social factors, which is where social learning theory and those other theories that include, the wider social environment is useful. But COMBI, because it's quite comprehensive, you look at the behavior change wheel, it actually has space for everything in that one model. And that's why we've tended to go down that. But it is quite a process to work through, but it is based around evidence of what works in terms of behavior change techniques for different conditions and behaviors that are problematic, with health outcomes that are problematic. So we've been using COMBI models in a lot of our research and evaluation for quite a long time in New Zealand, and some really good examples that are published. If you just search on COMBI name and behavior, you'll find there are papers out there, and you'll see how people have approached it. It's sort of flexible, but it's very comprehensive. And the idea was to try and integrate all these different theories, because there's literally hundreds of theories of behavior change. And this is where we've kind of prefer that. So that's what Dilla's, he's had some experience with it, and that's why we're kind of promoting it as a preferred approach to take where you can. But it's not the only one, and there's no definite right or wrong answer. Okay, we've got time for a couple more questions. Dilla, will knowledge, attitudes, and practice surveys, KAP surveys, be useful for assessing behavior of people?
I think just only from my experience, when I was in my research, my PhD, I wanted to understand smoking behaviors among Muslims, why they smoke, what are the barriers, and what are the enablers. And knowledge, attitude, and practice can shed some light into the fundamental underlying factors, but as I think, as Chris said, it gives you a shallow understanding. Yeah.
Yeah, I kind of like it to a skeleton, but we need to put flesh on the bones for the skeleton to come to life. And so if you like, the quantitative is like a skeleton. It's a good framework for getting some structure or sort of understanding, but to get the real richness in the movement, kind of the dynamic, you need to talk to people and hear their stories and listen to what they're saying. And that's where the qualitative methods integrated. So both are important, I think.
Yes.
One without the other is often, it's like the cake hasn't been baked properly. We go back to the cake metaphor in a slightly different context. Good. And then there's another question. How have you used the findings from your research, this is for you, Dilla, to implement interventions or advocate for better infrastructure or facilities to overcome barriers?
Yeah, so when we did the qualitative interviews with smokers, Muslim smokers who currently smoke and used to smoke, we got a better understanding of the reasons, barriers, enablers, and so on. And then we did the behavioral diagnosis using the COMBI model. So for example, a lot of people talked about addiction. A lot of people talked about addiction. A lot of people talked about being curious to try smoking. A lot of people talked about friends and peers who smoke. So we mapped those findings or factors into the COM-B model. For example, we know, okay, this is related to the capability. This is related to the motivation. For example, addiction was always related to the motivation, reflective and automatic motivation to smoking. So understanding that, we were able to choose the appropriate behavior change technique. For example, understanding that, okay, the social circle is very influential among Muslims. Now we know what to choose in terms of behavior change techniques and how to tailor it. Okay, and the COM-B model helped us understand this mechanism. For example, I'll give you an example of the normalization and acceptability of smoking among Muslims. It is very accepted and it is very normal to smoke. Actually, it is expected in some culture. So knowing that, we mapped it through the COM-B model, and then we said, okay, what are the behavior change techniques relevant or would be effective to tackle this normalization, normalization and acceptability of smoking among Muslims. And the behavior change technique, one of them is framing or reframing. So we thought, okay, an intervention here would seek to reframe smoking, to denormalize it, to say, no, it is not normal, and also adapt it to the, we can tailor it and adapt it to the audience. For example, the audience are Muslims. So what are we going to use to reframe that? We're going to use religious context. We're going to use religious quotes in order to denormalize smoking among the Muslims. I hope that answered the question.
That's great. And Gay's just answered one of the questions about how we approach behavior change in public health around promoting wellness and just the accessibility of parks here. We're very fortunate is that, you know, it's not as hot or humid as in many of your countries a lot of the time. And we have got a lot of public parks. For example, just across the road where we are, there's a huge park where we can go for a walk at lunch break or even the evening. I live very close to a park. It's not everybody, but they are very common, more so than many big Asian cities. And so and having footpaths, I think, can make a big difference. You know, when city planners are designing roads, so they should put a footpath so that people can walk on the roads. I remember being in Bandung last year and trying to go for a walk, and it was really tough because it's a beautiful city, but I tried to get out of the hotel and it was hard to walk on the footpath. And if I stepped on the road, I risked being hit by a scooter. So I, maybe not being a local, I didn't know how to make my way around, but it was a great place to be. And the food is fantastic. People are very friendly, but it was hard, you know, to find a sort of a clear path, and it was kind of had to concentrate all the time. But I'm sure if I was there for longer, I would have got used to it. But it just is a little barrier for me to get out and go for a walk, you know. So I ended up going to the gym in the hotel I was at, which I prefer to go and see, you know, the outside world and breathe the air outside. But that's just one of my personal experience of that. So yeah, it depends on your environment a lot. You know, some of these barriers, but also availability. Do you remember during COVID-19, hand sanitation were put up everywhere, and if they were in our university, we've still got the dispensers all over the building. So if I think, oh, I just need to, you know, wash my hands, it's very easy because it's easy to do. It's accessible. It doesn't cost me anything, and it's readily available, and I don't have to think much about it. It's not too hard to access, and so it's like having free masks widely available if you're going to be in public spaces during the pandemic. So and some countries did that really, really well, and some countries, you know, it's a big expense and they didn't afford it or didn't believe in it or whatever. So for individuals, sometimes it's easier in some settings, and sometimes it's harder depending on the policy context and the physical environment. Yeah, so I think we've got some examples from New Zealand, but you know, every country's got its own. It's worth thinking about some from your own experience. Accessibility, yeah, it's absolutely. Okay, we're just about, I think we're out of time. Dilla. Any last comments? Or here we are. Thank you, Dr. Dilla, for your presentation. Very exciting. How about that? Example in Vietnam in terms of vaccination, changing parents' behavior directly determines vaccination coverage rate. And lots of information there. Thank you. Thank you so much for sharing your insights. Oh, there's a lovely park that Gay's just shared. You can click on the link in the break. But we're going to go now to a break. So thanks for your questions. Thank you, Dilla. Great presentation. I'm proud of you as my PhD student. And I think you did a great job. Don't worry about the technical things. We all struggle with those sometimes. I've been in very embarrassing situations in conferences where things wouldn't work, and so you've got a supportive audience here, so no need to worry.
I'm very happy. Yeah. Thank you all
Okay,
for.
So we're going to break for I think 20 minutes, if that's okay, and then we'll come back and have a follow-up session, which will be on monitoring, research, and evaluation. So picking up some of the things we've just been talking about, but going deeper as well. Okay, we'll see you soon. 20 minutes time, and I hope you had a good break, and maybe, did you make some healthy choices? Go for a walk, get some fresh air, have a glass of water, or was there something sweet that passed through your lips? we all make these choices all the time, every day, don't we? Okay, so what we're going to do in this session is just to revise. I'm sure a lot of you are very familiar with this sort of thing, is talking about the monitoring, research, and evaluation. Sometimes it's called MRE, or sometimes you'll see it framed in different order, research, monitoring, and evaluation, etc. But we're sort of talking about in some way of assessing the value of a program, an intervention, a project, that kind of thing. So I just thought how we can, if we know what we're doing, and we can, the motivation behind doing this is to improve things. And so if we find out what's not working as well, and we can get feedback about it, then we can improve it. And that's one way of strengthening public health, is sort of investing, if you like, the limited resources we have. And that's not just money, that's also person, time, energy, and effort, political capital sometimes, in the right things that are going to get the biggest impact for the particular population group. So that may be an equity impact, it may be across the whole population. So let's just explore this topic a little bit further. So the kinds of things we're going to cover around distinguishing monitoring, research, and evaluation. Look, to be honest, there's a bit of crossover, but we'll try and unpack them a little bit. Apply some key frameworks to program planning. We're trying to draw on the CDC framework and the RE-AIM framework for evaluation, and then look at suitable how we get data and indicators and package them together. And the whole objective really is to help us improve what we do, and hopefully have better policies that are based around good evidence, rather than just good ideas of what people think is effective and the right thing to do. So the distinction between monitoring, research, and evaluation can be simplified as this. And again, as I said earlier, it's a bit of blurring of the lines and the boundaries. But think about monitoring like a wearable device. You might have an Apple Watch or something that provides continuous tracking, for example, of the number of steps or your heart rate or something like that. So think of that as a sort of a continuous tracking over time of inputs or outputs. Could be activities like steps, but the outputs, it might be some health outcome you might be tracking, like you might go and have your blood pressure measured every month or something like that. But it could be immunization coverage, would be a monitoring, usually over time. The time dimension is important. And then research is time bound. So time is important, but it's usually more like a snapshot than a movie. If you think of monitoring like a movie going forward, research often takes a snapshot or a shorter time frame, and it's got a very specific question that it's trying to answer or unpack. So it generates new knowledge, hopefully that could be potentially generalizable to other settings. Sorry, I've missed a letter there. I should have checked in my research. Testing via a randomized controlled trial, for example, of an app to help people quit smoking would be an example. And then thirdly, evaluation is more taking snapshots over time, periodically judging, and often the longer time, like every year or 3 years or 5 years, you've got a program running and you want to say, is it achieving its goals? Is it meeting its budget? Is it having an impact on the target population or not? And we see these tools are applied not just in the health sector, right across the board in all sorts of domains and sectors. But they can work together in ways. So if you like, seeing what they kind of feed into, if you like, monitoring feeds evaluation. Evaluation then can raise new research questions, which can then be go and sort of commissioned research projects to go and improve, say, the indicators that monitoring should look at, or digs deeper to kind of unearth questions that have been raised by the evaluation. So, and I'll show you an example of a live project I'm leading at the moment that uses all these 3 tools. But just to say that they're really important, because really important one is accountability. You know, are we delivering, is the program delivering what it promised? Is it good value for money? Is it reaching the right people? Is it providing learning so that we can continuously improve our programs and outreach? Is it providing information for evidence-based action? Does it feed into strengthening a health system's performance and outcomes? That's a major role for monitoring, research, and evaluation. So one big example is our smoke-free strategy. We have a goal of becoming a smoke-free nation in New Zealand by the end of this year, right? And next week we're going to hear what the smoking prevalence is. The last time it was measured, it was just under 7%. So about 7 in every 100 New Zealanders overall replied to a survey that they were smoking, but which is really good, you know, compared to many countries in the world. And it's dropped a lot over the last 10, 20 years. And we've been monitoring it. But right now we're monitoring it really closely, because we've got this accountability for trying to get below 5% for all New Zealanders, or population groups, socioeconomic groups, ethnic groups, by the end of December 2025. I'm a bit nervous that we're going to miss the target, because I don't think our government has been investing as strongly as it could have done with tobacco control initiatives. So I'm very interested in the monitoring, but I'm hoping that even if we do miss it, or even if we make that goal, we've still got work to be done after 2025 in helping even more New Zealanders quit smoking and not start smoking. So the monitoring needs to go on, but specific programs have been funded by the government to try and, you know, address smoking, say, in certain population groups. So each of those is contracted by the government, so they're spending lots of money, and they want to make sure that, you know, the return on investment is good. So evaluating those programs is an important part as well. And then there's research that's been commissioned to dig deeper into, you know, the reasons why certain groups aren't using smoking cessation services, or why they might be more successful than appears, or what are the barriers, you know, that we've talked about in the previous talk. So it really is important to health systems performance, for strengthening the performance of our systems, for getting better outcomes, for having enabling decision makers to, say, shut down some programs and start others up. You know, shut them down if they're not achieving the goals, and start up new ones based on the best available evidence of what works. So this is an example of a project I'm leading for the Ministry of Health in New Zealand at the moment. It's called Research, Evaluation, Monitoring, not monitoring, research and evaluation. So it's different order, of illicit tobacco and vaping products in New Zealand. And we've just sent the report a month or 2 ago to the Ministry of Health, and it hasn't been published yet. I'm not going to tell you the results are, because I can't, because they're confidential until it's published in the public domain. But you'll notice the title has those 3 things in it. And so I thought I'd go and have a look at the contents, if you like, of our report on this is black market tobacco, so sold without paying tax. People are selling cigarettes cheaply without paying excise duty, and vaping products, are they being sold to the wrong people? We have restrictions on the sale of vaping, what's happening there. So I was commissioned to lead a group of researchers to undertake this research evaluation monitoring, and this is kind of the contents of the report that we looked at. So I've highlighted them in different colors, where I think the red color is, we go back, is monitoring, the green color is evaluation, and the research is sort of purpley color. So so we've got this particular piece of work that Pipi, who's away in Australia this week, so she's been doing as part of her PhD, and this is called consumption gap analysis. And that is looking at the difference between the amount of people reporting, amount of smoking that people report, and the number of cigarettes that they collectively consume, versus the amount of cigarettes that are released legally into the New Zealand market. And the difference between the two is what we call the consumption gap. So it's probably likely that there is a proportion of cigarettes people smoke that is illegal, that avoids paying tax, and we're trying to capture that. But we're doing it over time. We've done it retrospectively to get a sense of what's been happening over the last 10 years, because we've got data on that's available, but we're also doing it prospectively. So poor Pipi, for her PhD, every year she has to update, while she's doing her PhD, she has to update the data because there's new data released. And she has to recalculate all the estimates. So that's a kind of a mixture of, it's feeding into her research, but it's actually a sort of surveillance, because we're tracking over time in a semi-continuous fashion. Every year we're doing this and providing a report back to government. We're also doing these intermittent kind of the deep qualitative research interviews with senior customs officials to find out what they're encountering at the border with interceptions of smuggled tobacco products. And that is going into our consumption gap analysis, and this next one, which is cyber and social media surveillance. So that's kind of monitoring again. And I have a research assistant who's also one of my PhD students, Ming Li, and she's tracking social media. She's from China, so she speaks Chinese, and she can read, she's got access to social media platforms that Chinese population in New Zealand use. And most of our illicit tobacco in New Zealand comes in from China, and it's often promoted in Chinese language on those websites. So I'm not blaming Chinese people here at all. I'm just saying that's the fact. And so she's able to monitor that by understanding the kind of different words and code words that are being used on that. We've got a Power BI dashboard set up, and an algorithm that tracks on a whole lot of keywords that we've developed from our qualitative research interviews with people, to know what platforms and what language people are using to try and market illegal tobacco. So that's an example of monitoring and or stroke surveillance. And then the regulatory landscape of vaping is sort of, I'd say that's a review of other countries and how they regulate. So it's kind of more like a pure research piece. Compliance analysis, we do secret shoppers going into stores that sell vapes and checking whether they're complying with the underage sale regulations, age ID, and the amount of nicotine in the vapes that are on sale. And we've done that in about 135 stores in 3 cities in the last 2 years. So it's ongoing. So to that extent, it's a bit of monitoring. It's a bit like research. We're going to publish from this. So there's a bit of an overlap. The market surveillance is looking at interviewing with the people who retail these products. And then we're doing some deep dives with consumer behavior. So we've done some research, which is analyzing data collected from 200,000+ 14 and 15-year-old students in New Zealand every year. And we're analyzing that data to look for the sources of vapes. They're underage. Where do they get their vapes from? So we're doing that through quantitative manipulation of the data, or analysis of the data. We're doing focus group discussions with teenagers and young adults to sort of give us some more depth around that and some insights, which can then feed back into our analyses. And then we're also got a project analysing websites of people who sell vapes to try and understand new products and where they're going and that sort of thing, whether they're advertising to young people and marketing at young people. They are, I can tell you, in short. So that's it's a concern. And we feed all this back in an annual report to the Ministry of Health, but I also provide quarterly updates. And that is very interesting work, I have to tell you. But you can see it's a kind of combination of all three things: monitoring, evaluation, and research. Mainly monitoring and research. Okay, but overall, I would say the overall project we could evaluate. So at the end of the contract, we can have a look at the whole program of work and say, in an evaluation, was this a good investment of government money, and should they refund us to continue doing this work? That would really be the evaluation piece. So it's kind of zooming out a bit. So does that make sense? So that's just an example of how there's a bit of blurring between the different words that we use to describe the activities. We'll come back to some other words that we can use just to help embed those. But underpinning evaluation and monitoring often some frameworks and theories. We like theory. As you can tell, we've mentioned it quite a lot in this course. And I'm just going to very quickly run through logic models or log frames. Some of you who are involved in program project management, you'll be familiar with this. It's essentially a sort of framework for systematically listing out the inputs, the activities, the outputs, the outcomes, and the pathway to impact, essentially, from all the different inputs in a systematic, explicit way. And then we've talked briefly in an earlier session about theories of change and why they can help us, because they seek to explain when you set out to design a project and also evaluate it, how and why things happen. And then we'll look at some frameworks that I think are really useful: the CDC framework from the Centers for Disease Control in the US and the RE-AIM framework. Okay, so here's a public health logic model. I've just downloaded this from the template lab, so you can actually download a whole lot of these yourself, these kind of templates. It's an editable electronic. It's just this, you could do this in a table in Word quite easily, but it wouldn't look quite as fancy, although some of you may be able to do that. But it's just a series of columns and rows, essentially. And essentially, you've got a situation description, which says what is the situation, what's the issue, what's the problem that you're trying to address through your intervention. And there's your inputs, your outputs. You might have a whole lot of outputs that you're after, and then outcomes. So outcomes are more like the desired end point, but they might be short-term, intermediate, and long-term. So, for example, our output might be the number of people who quit smoking, but the outcomes might be reductions in lung cancer, COPD, and cardiovascular disease. So these are more sort of short-term kind of products of the immediate intervention from your inputs. And then running along the bottom, it's got external influence and outside factors. Not all logic models include that bottom line, external influence and outside factors. So here we're thinking about what's going on politically, economically. That might be, it could be a natural disaster, to sort of explain what we see here. That might be explanatory. So this is helpful in designing, but also in evaluating. And a theory of change, I think it's a bit more organic than that kind of, very structured, systematic log frame model. The theory of change is really just about how we explain how activities are understood in order to, how do they contribute to results that produce the final impacts. And that's a UNICEF definition of a theory of change. So it's kind of if-then. So if we do this, then we expect that. So we go from the current situation. So if you flip that around 90 degrees, it looks a little bit like the log frame, but it's actually a bit more organic and often best presented in a more fluid fashion with a lot of context wrapped around it. So here we are in this model. You start with the blue lines, and I like the way they start with assumptions. So it's good to be explicit about the things that we naturally assume. And if we, we often assume and leap into action without testing our assumptions, and then that becomes problematic down the track when we realize the things we assumed would be the case are not actually the reality. So, for example, we could assume that all communities and their voices are equal. Well, that's probably not realistic. In fact, there might be some that are very dominant, more powerful, that might intimidate other communities whose voices are not heard. So assuming that may not be a good assumption. That individuals have the ability to change. Well, that's an assumption. As we've talked about, there's a lot of factors in behavior change. And while people do have the potential to change, they may not always have the capability or the opportunity to lead to the motivation to change because of all those policy factors or social factors, depending on whichever behavioral theory you choose that Dilla, went through. And it's not just to change their own behavior, but also to change, institutions and systems that they're pushing up against, whether it's the justice system, the legal system. It might be the landlord who's difficult, to get affordable housing for a family, and people feel disempowered and marginalized, and we might make an assumption that, of course, people are all just like us, and of course it's easy for them to go and knock on the door of the powerful landlord and demand, something to be improved, whereas in fact that could have a very bad outcome for them, and so they don't do it. So these are all assumptions, and I think it's good in the theory of change to be explicit about these assumptions, and also to think about relationships that already exist. We often, as outsiders coming in to lead a project, we've got a time frame and a mandate, and this goes back to our community development and strengthening community action session. Relationships and trust. We talked about this in the context of immunization as well when we're talking about disease prevention, how trust and confidence and relationships are really, really important. But when we come to work with communities, they've already got existing relationships. They've already got existing human capital, certain assets and strengths, and that we often ignore. And we think we're starting from, ground zero, but actually we've got a lot that people bring a lot to the table. Financial resources, often the communities we work with have very few financial resources. Sometimes we come with financial resources, and that's leads to a power imbalance. Again, that's an assumption that we need to be really explicit about and to get out on the table. And then there's often an information discrepancy or imbalance. And we often assume everybody knows, of course, that smoking causes lung cancer, but actually not everybody knows that, And so some of these assumptions we might need to test in some preliminary research, and that might be some focus groups or a brief survey that could be done in a very, it could be done in a community workshop. That's often a really good way of bringing people together and doing something active and co-creating some mapping around, what the strengths and limitations and barriers are in their community. And then once we've got those, we need to think about, some of the preconditions for change, like accountability, that we've got the political and civic and legal space to operate, that some countries it's legally problematic to have meetings. So we need to operate within the law and the constraints that we're in. The communities are actually willing to participate. There's no point trying to work with a community if it's not, and then the partnerships are available to help make that change occur. And then we come into our outputs, outcomes, and both short-term, intermediate, and longer-term outcomes along the bottom. And there might be, and impact is really what we're all about. But along the way, there's a lot of learning, a lot of relationship building, a lot of strengthening capacity, a lot of experience that's gained. So even if we don't have the kind of impact that we might expect from our original theory of how change will occur, there are often tangible collateral benefits for the community and the external people involved in monitoring or evaluating. All is not lost. And probably I'd say most of the programs and projects I've been in, including research projects or community-based programs, We haven't always achieved everything we set out to achieve because of external factors or assumptions that we made that were wrong or that things changed over time. But along the way, there are a lot of less tangible, almost what you might call secondary benefits. And that may be just strengthening community capacity, strengthening community efficacy, you know, the kind of collective consciousness, and empowering the community to take control of their own destinies more than they had before. Okay, so starting off, you know, getting off the ground at the beginning is really important, to have a theory of change and think about planning and being very systematic and explicit in, you know, our assumptions and what we're hoping to achieve with our outputs and our outcomes, and how they might connect is really useful, because those maps that we create, or diagrams, if you like, they can become the key points where we might measure things when we come to do evaluation. So this is the CDC program evaluation framework, and the link is here, and I've put it up on Canvas as well. And like a lot of these things, that, you know, it starts at the beginning, at the top, assess the context, describe the program, focus the evaluation questions and design, gather evidence, credible evidence, generate and support the conclusions, act on the findings. So it's a circular process, right? And around the outside, they've got these three factors that sort of support, engage collaboratively, the sort of principles, learn from and use insights, and advance equity. And then in the middle, they talk about these 6 standards: relevance and utility, rigor, independence, objectivity, transparency, and ethics. 5, if you bundle independence and objectivity. So we can unpack each of those. Rigor is really about doing things really, really well and testing that validation, right? Relevance and utility is that they're actually going to be useful to people. The standards, the things that we find, or the things that we measure, are going to be useful to the people who are interested in what you're doing. Objectivity and independence means we're not, that the people who do the evaluation should be at arm's length from the people inside the program, and being really transparent about that and your connections. For example, if my wife was doing the evaluation of a program as I was leading, and we didn't declare that that was the issue, that was a relationship, that would not be transparent, and people might question the results of the evaluation because of that relationship. She might be, of course, she has an incentive to make the outcome look very positive, but because, you know, she wants to boost my whatever standing or something. So ethics, you know, doing the right thing, doing it properly, the ethical principles we alluded to in the early sessions about doing good, not doing harm, being fair, and valuing people's autonomy, they all come into play here. So that's quite a useful framework for thinking about conducting evaluations. And if you go onto their website, it's broken down in each of those steps, and principles and standards is all articulated in depth. Okay, now I just want to introduce you to, oh, hello, we've got another guest on the show with Aldelia. Hello, very welcome. So we've got 2 related frameworks, and I've used REAIM, not PRISM myself, but it's really a kind of REAIM plus that takes into account sustainability a lot more, thinking about policies and the policy context more than the REAIM framework does. So the REAIM is a whole kind of enterprise. You can go onto the website, and there's a link to the website on Canvas resources and readings. And I'd encourage you to go on. It's kind of like a whole massive enterprise, which has got courses and conferences and all sorts of useful materials you can download. But you boil it down, it really is just 5 words that provide the basis for a framework to planning and evaluation of programs. So as I say, most of these frameworks are useful at the beginning and along the course of a program. So for the design, but what goes into a program, but also how you evaluate its impact, its effectiveness. And so the REAIM stands for these words: reach, effectiveness, adoption, implementation, and maintenance. Reach, so how many people were reached by the program? Did everybody get the same level of reach? Was it equitable or not? Effectiveness, that's really about impact, and you might not be able to, the program might not be funded for 5 years to measure outcomes, but it might measure outputs. And so sometimes we have to make a leap between outputs and outcomes. The outputs might be, you know, some intermediate thing like the number of people who participated, and that's reach, but then the number of the average number of steps that people increased to walking every day. So that's effectiveness, but it's not actually telling us what the health benefits are. It's telling us about somewhere between what people did to reduce the risk of physical inactivity, but not actually weight loss, diabetes prevention, or heart disease prevention. That's an outcome. Adoption, yeah, is uptake. For all the people we reached, what proportion of people took up and got involved in fully in the program? Implementation might be, you know, actually, did we implement the whole program in full, or was it interrupted in some way? You know, maybe in some communities it was implemented in full, other communities it didn't quite get off the ground for all sorts of contextual reasons. And then maintenance, you know, has it been sustained or sustainable? So these are really useful factors. They've been tested in many programs and projects all over the years. We use it in some research projects sometimes. It's very helpful. And then PRISM stands for the Practical Implementation Sustainability Model. Phew, Practical Implementation Sustainability Model. So it includes these kind of high-level factors in the context that are relevant to the re-aim outcomes, like policy and planning and those sort of things. So here's the re-aim, just going again from reach. How do I reach the targeted population? Effectiveness, how do I know my intervention's effective? Adoption, how do I develop organizational support to deliver my intervention? So that's interesting. Implementation, how do I ensure the intervention's delivered properly? Maintenance, how do I incorporate it so it's delivered over the long time? So those are some questions you might ask using the re-aim framework, depending on the nature of a particular program for an evaluation. And so here's PRISM. Again, you can go onto the re-aim website and you'll find the extension for PRISM and have a look. But the contextual factors, program, practice and policy, and implementation strategies. So it's got re-aim down here, reach, effectiveness, adoption, and then implementation strategies, intervention, policy or program, and then, you know, these other factors like the external environment, drivers of inequities, sustainability, infrastructure, multi-level sector perspectives. So you might be starting to out here to get some input into your evaluation from other sectors. So for example, if I was doing a fetal alcohol spectrum disorder health promotion program to help women who have been drinking alcohol and or to stop women drinking in alcohol, when as soon as they recognize they might be pregnant or are pregnant, no alcohol, you know, I know that's a no-no in many cultures, but actually it still goes on. So how we do that, but we might need to bring in the education sector. What do they think about the program that we're developing and designing, and have they seen any benefit from it in another sector? Or it might be the social welfare sector or the legal sector, justice sector might have something to say. And what about the partners who took part? Might be the police, might be social welfare support, might be some NGOs who support families who are struggling. It could be other sectors you might think about. It's very multi-sectoral, by the way, FASD. It's every child who has this problem is massive implications for their lives. So something to be aware of. So that's that one. That's much more complex than the simple 5 elements of the re-aim framework. So when you come to evaluation and monitoring, particularly, and obviously research, you're going to draw on well-established methods that are used in research projects specifically, but you may not go the whole hog. In other words, it's very uncommon for evaluation projects to use a randomized controlled trial design. Because it's sometimes completely unethical to do in the setting of a community-based intervention, or it may be just too hard and expensive and complicated. It's just, and it's maybe that the answers you might hypothesize you're going to get are not worth the investment. So you may have to fall back on other sources of evidence that aren't quite as rigorous, but might be sufficient, like a before and after study, and using some sort of comparison population outside the area to kind of track, just to kind of cover off the risk of any, there might be some general trends in society, and you want to make sure that what you think is improvement could be not just due to your intervention, but it could just be through improvement overall that's happening in society. So, for example, smoking prevalence reduction, we think it might be due to some education campaign on TV, but actually it might be due to some other factor amongst young people substituting cigarettes for vapes that was going on social media promotion that we didn't take into account. So you have to be careful about the judgments you make about effectiveness. And so having a good evaluation design as best you can with the resources you have available. So it may be quantitative, like surveillance, surveys, trials sometimes. It's more likely to involve qualitative interviews. It might be with key informant, called KIIs, key informant interviews with key stakeholders. It might be, a community leader. It might be, or community leaders. It might be participants, people at the grassroots, ground level. It might be people from other sectors. It might be you want to get some voices from young people, older people, middle-aged people, from women and men. From different sorts of family structures, people who are working and people who are unemployed. So trying to get diverse voices in those interviews and focus groups, case studies. And, you choose the method for the particular question, and you're trying to find the best way of getting that information. You might underpin some of this with a literature review as well to see what other people have done. By the way, I didn't put that in, but that's something to think about. Typically, the work I do, we use what we call mixed methods, where we draw on both qualitative and quantitative methods to get that skeleton with the flesh on the bones to tell the whole story. And, with evaluations, you're taking into account usually the time course. So you want to hear the story from the beginning. There are process evaluations, formative evaluations, and summative evaluations. Lots of terminology used in the evaluation space. Formative evaluation often involves the evaluator getting deeply involved from the very beginning of a project and feeding back about its design from sort of day zero onward, and then asking hard questions along the way. Process evaluation, an outsider comes in and maybe documents everything, collects those documents, reviews them. Not so much intervention with the team running the program, whereas a formative evaluator can actually shape the course of a program. And then we do often outcome evaluations is often what people focus on because they want to measure things, hard things at the end. But it is really good to think about early stages, getting someone involved in evaluation. And if you can't get an external person, get someone who's maybe in the program but not deeply involved to actually oversee make sure everything decision-making meeting is documented, so that you can explain what happens and why it happened down the track. Otherwise, 2 years later, you will forget why you made that particular decision, which changed the course of a program. And then these kind of issues at the bottom there, like bias, because we developed the program ourselves, and so we really want it to succeed. And so our evaluation, if I'm involved in the evaluation, I'm more likely to say, oh, it was really good, people loved it. And we introduce bias into the findings. We want to validate people's responses and the measures that we have. If we're going to take samples of people to give their perspectives, we want to do that in a rigorous way, and we always have to be thinking about, are we doing the right thing when we do this kind of work, just like when we're doing any kind of standard research project. So indicators are an important part of evaluation. We have to have some sort of measures. Often a funder will demand certain deadlines for certain things to be reported on, and typically they are good if they are smart. In other words, specific, measurable, achievable, relevant, and time bound, just like setting objectives for any kind of, organizational strategic plan, same sort of idea, being really specific. Can you get a lot of the data you want, the measures, can you get them collected routinely from a program? Like we've set up a digital dashboard to monitor the illicit sales on online social media platforms. So that electronic and digital format now is helping us. But are there other sources of data that we should be collecting, maybe more manually? Are there other surveys that are going on that could validate the data we're collecting or shed light on it like other surveys? Are there sentinel sites that could give an early warning signal of a change going on? These are sort of other sources of data. So, for example, in New Zealand, we have a New Zealand Health Survey. It's run every year. It's face-to-face questionnaires with thousands of people in New Zealand asking about all sorts of questions. And the one I'm really interested in at the moment is the results on tobacco use trends, because they're getting published next week, and we'll know whether what we've been doing in tobacco control in the last 12 months has been benefiting and reducing tobacco smoking. But there are some global surveys that are done on a reasonably regular basis. So the GYTS is the Global Youth Tobacco Survey. It's run in many countries around the world. It's supported through the World Health Organization, and it kind of tracks how performance is according to for young people, but it's loosely based on the Empower framework from the WHO, at monitoring, protecting, offering, warning, enforcing, and raising taxes. So they ask young people in different countries around the world about their knowledge, attitudes, and practices in regard to tobacco and nicotine products. As that's an example of an intermittent sort of running survey, a monitoring thing more than ever, But you could imagine going in and doing in-depth interviews as well to supplement that. Particularly after you've had a look at the data from the survey, it might generate some questions, and then you want to go and do some in-depth interviewing. That's not funded through these regional bodies or WHO bodies usually, but it could be something that a university does to dig deep for a particular country or part of a state within a country. If the survey has flagged an issue, for example, you could go and do in-depth research. Okay, so just moving along. Using findings for action, well, that's pretty important, isn't it? There's no point collecting data if we don't actually, if we aren't ready to act on what we find. Otherwise, that's unethical, essentially. So, but how we can translate the information into something that is meaningful to decision makers and to the public is really important. So, visualization of data in interesting ways or in short form versions to make it for busy politicians to absorb the information, or for the semi-literate public to get a hold of. I think we have to be much more creative and do better in public health than we've done in the past. We also need to think about, improving all the time in both our ability to conduct evaluations and monitoring and how we report it. And so taking a kind of continuous quality improvement approach is a good one, which is processing, getting feedback, and then trying to improve. So taking a sort of evaluation embedded approach to communicating what we get from the evaluation. And so, you can use health services as a good example, where we do evaluations and then we redesign the services according to the evaluation. Okay, this is just an example of a one-page fact sheet for Indonesia from the Global Adult Tobacco Survey that was done. And this is on a page, all the data summarized. Now, it is a bit busy when you look at it, but if you used this, you could highlight for a local politician, you could sort of send them this with another sheet of paper which just said some 5 bullet points. Yeah, if we could just cut the microphone. Thanks. Yeah. So you can see it's on this, mainly it's tables of data, which is a bit boring and you have to really look closely, but it does have a figure. I think there's room for improvement. So a continuous quality improvement for this would be, objective would be to test this with the people who it's targeting to be aimed at, and get their feedback on how to improve it and make that information more digestible, and which bits of data are most important to them for making decisions. Because let's face it, your Minister of Health or whoever in your government is responsible for tobacco control has probably not got the time to even look at this in detail. But they want just a one-page thing with maybe 5 bullet points and some recommendations on it, but maybe one graph or a small table with a few things on it. So getting some feedback from officials and other people like that who can give you information could take what is actually not bad, but turn it into something much better. So again, continuous quality improvement of our evaluation outputs. And then just sort of starting to wrap up here, when we do a monitoring, research and evaluation, as I mentioned with research, we need to, you need to get informed consent, make sure we're maintaining confidentiality and protecting people. There's cultural safety. We're not, stigmatizing people in the process. Who owns the data and where it sits? Is it securely stored? Are we framing up certain groups of people as being bad or at fault, or when they are actually the victims and we're blaming the victims, and we don't want that to happen? There's been a lot of, that sometimes researchers have been guilty about telling the story in a way that's very focused on the deficits of groups of people rather than their assets. So it's important that the people who are being talked about or reported on have a say in, what's published about them. And so that's, and the data, who looks after that data and who interprets and analyzes it is important. So that's data ownership and stewardship. And then always thinking about having equity-centered evaluation principles. If you remember that CDC model, has got equity. There we are, around advanced equity, just on that top left-hand side. And the REAIM framework also incorporates notions of equity in the PRISM, how they address it through thinking about the determinants of health, really, and how they're distributed. Okay, so we need to build capacity in this area, and many countries don't have people who've got experience with evaluation or research or monitoring. So they do need to be built in to our systems so that it become like the normal part of what we do. So if we're going to set up a new program, we need to think about evaluation as part of it, not as an add-on, right? Not after the fact. It should be there, thought about on day one. So that might mean we need to train, mentor, and develop partnerships, for example, with academics to weave them into programs if they're government or NGO programs. And when we embed them, there is a resource implication. And my rule of thumb is that at least all new programs should have at least 10% of their budget allocated to evaluation. And that's kind of a useful little working rule. It's often ignored and overruled, but at least it's a good starting point for debate and discussion with the people who are funding a program. They want to spend all the money on the program. It's a new program or in a new setting, and we need to learn from it because it's easy to make mistakes and get things wrong if we don't do it right. And that's why evaluating is so important. And it's the same with, any kind of other form of tracking what we're doing to see whether it's effective. So key takeaway messages, and then we've got time for some little bit of work and some feedback. Monitoring is kind of like tracking over time. Research is more like testing, and evaluation is more like judging an overall body of work, whether it's effective or not. We can use frameworks like logistic models, REAIM and CDC to help design and look at the outcomes. So link the actions that we build in at the start to the outcomes or the outputs and the outcomes in that order, to judge their, whether they're making a difference. And really that theory of change is a sort of more organic approach to thinking about the assumptions and the context that we build into these models. And then finally, it's really important, I believe, to integrate these elements of monitoring research and particularly evaluation in public health programs as part of continuous quality improvement and making sure that we are accountable both to the funders but also the communities that we work with to implement these programs. So I'm going
Chris,
to stop.
I think Albilia has a question in
Okay,
the chat.
okay, let me just have a look. Can you read that out for me, please?
Yep. So in Indonesia, one of the challenges for sustainable programs is that mostly no allocated budget for monitoring and evaluation actions, even from the government. As initiators, leaders of the program, is there any strategy or approach to convince the funders, stakeholders?
I knew somebody was going to ask this question. It's a really tough one. I think it's kind of like educating those people to understand the value that evaluation monitoring brings. And I mean, intuitively, I think most people, if you took it out of, the context of health sector or a program, if people have bought a new car, they want to take it to the mechanic every now and then just to make sure everything's running properly and to tune it. It's not really a lot different from that. We've got a dashboard on a car for tracking if the oil temperature is correct, that the revolutions of the engine are not too high. So, in many aspects of life, we do this and we invest in it. It costs extra to go to the garage and take the car in regularly for a checkup. So I don't know if that's a really good metaphor, but sometimes, you have to kind of convince decision makers that we do need this, particularly if it's a new program. But I'm not saying older programs shouldn't, because context changes and so forth. But particularly with new programs where there's more potential, particularly sometimes to do harm if we don't get things right, to invest in all that upfront preparatory work and with the communities who are likely to be impacted, and then ongoing engagement and feedback and tweaking and shaping and documenting all of that so we can learn. And then if it's going to be scaled up, then we've got all that knowledge and experience that we can use to design even better form of that program for a different setting or population, right? So it's particularly when you're setting things up, I think we just got to find better ways of communicating with our decision makers and say, look, I know, even if we can only get a few percentages of percentage of the funding to go towards evaluation, for an evaluator to spend a lot of their time doing these things, that would be really, really helpful. So I think finding some sort of metaphors that might work for that decision maker and convincing them, and drawing on the literature. There's a lot of literature around the need to have evaluation. I don't know, another metaphor might be someone has chest pain and they get admitted to hospital. Imagine that if you didn't have an ECG monitor put on you, lying in bed in a hospital without an ECG monitor, or a nurse coming in and asking you questions from time to time. Is that medicine working? Have you still got pain? We do, that's a kind of form of monitoring and evaluation. And so, in our day-to-day lives, we do this intuitively without even thinking about it in all sorts of elements. But when it comes to programs and projects like this, sometimes it just seems to be overlooked. And it's a blind spot that I think we need to challenge and push back against. So I think demonstrating, so trying to find the right metaphor that works for the particular decision maker might be helpful, so they can kind of go, oh, I get it now. And then the other way is to, I think, from a successful evaluation, show the value that comes from a well-conducted evaluation, how it adds value, how it has improved the program, it's improved its reach, its effectiveness, okay, etc., the re-aim elements. So, and therefore it's more likely to be sustainable and maintenance. I think, we've just got to use all our dark arts. Maybe we go back to the behavior change theory and think about, what are the factors that we need to do to to motivate our decision makers to agree to investing in evaluation and monitoring. And so that might be thinking about the things that incentivize and motivate them. And providing evidence is kind of a rational way. That's sort of like the health belief model. We say, we give you information, you're going to change your mind, and therefore you change your behavior. But probably it'll come about through maybe, well, those other people have got an evaluation and it's been really helpful. So it might be a bit of social pressure and competition, incentivization, other factors that often lead to the sort of changes that we need to have happen. Sorry, that's a very long-winded answer, but it's a great question and it's a difficult question. And probably I was so long-winded because I don't have a snappy there's no magic bullet, I guess is what I'm saying. It's a long-term solution. Okay, sorry. Any other questions before we just have a little bit of group work and for 5 minutes and then feedback?
Yep. Diana gave a suggestion, I think.
Yeah, sure. Okay, yeah, I'm all ears.
Yeah, Diana, would you like to read that, or would you like me to do it? Okay, I'll just read it. So
Yeah,
she
sure.
said, from my experience, the challenges for monitoring and evaluation also include data openness between
Yeah.
provinces and centers.
Yes.
Yeah.
Yeah. So the willingness to share data, is that what you mean?
Yes.
Yeah.
They
Yes.
said we are advocating for data integration so that we can check the impact of my
Yes.
office essential program.
Absolutely. Actually, someone raised this in an earlier session is in New Zealand, do we have any kind of platforms where we can share learnings from different programs and so forth? And I gave a few examples which weren't particularly good. We don't have a one site where all that is done. We have various patchy bits and pieces from different organizations who share that information in different monthly fora that are online that you can belong to for specific conditions like clinical networks or public health networks where people share what's working in their part of the country, that sort of thing. So I think we don't have a nationally wide up system for everything that's new or being evaluated. Sometimes they end up being published, but that's often not the case. So I think you're right that, there is the data sharing and openness is important. Without, obviously, we have to do that ethically and be careful about not identifying individuals or communities in a way that victimizes them or re-victimizes them. But we also need to, I think it's incumbent on us where we can to share the data where it gives us the opportunity to learn and improve things for the ultimate benefit of our people. Great questions. You're a great group to work with. And I'm now going to give you one last task before we finish up for the day. So I want you to break out into, if we can do the six randomly sorted breakout groups. And very quickly, just 2 questions for your groups. How is monitoring, research, and evaluation used in your current role? And maybe only a few people in the group this might be appropriate to. And then what barriers exist to using the findings? And then we'll just talk about that and maybe have some thoughts about overcoming those barriers when we come back. So I'm going to get you to do this super fast, right? This is super quick work. Speed dating. How is MRE used in your current role? And then what barriers exist to using evaluation findings? And we'll come back in 5 minutes and then a very short, sharp, no lectures, no essays, just a few bullet points from each group if we can before we wrap up. Okay, thanks, Juanita.
Yeah. Juanita, can you open it? Like 5 minutes.
Yes.
Thank you.
1 second.
If we can post that page up on the, where is it? Share, spotlight this share? No. Share to breakout rooms. Yeah. Yes. Right.
Okay, have you shared that, Chris? I can check.
Yes. Yeah.
Okay.
I think I clicked the right button, hopefully. So
I'll check it.
thanks.
Yep.
Okay, good. Right. Yoo-hoo, learned something new. Welcome back. Welcome back. Welcome back from your very mini speed dating session. And I understand some of you had technical difficulties, so we're not going to be able to have everybody talking this time and the time available. But just quickly, just a few shared experiences from the groups that were able to make some progress. How is monitoring, research, and evaluation used in your current role? So just in your group, I no doubt you had some sharing. Any kind of highlights about the different ways it's used And then what barriers? So maybe which group would suggest to go first that was able to get some progress?
I think groups 3 and 4 managed
Okay,
to
okay,
discuss.
good. So let's go with
anyone
group
from those groups.
Group 3.
Oh, okay, Prof. Chris. I'm Diana. So currently in
Oh,
my
good.
role, I'm working as can you
Yes.
hear my voice? Okay.
Beautifully, loud and clear.
Yeah. Currently in my role as a program associate, I'm in my office. We using a survey CTO for real time data collecting, but
Okay.
also sometimes the survey CTO is eligible for the like back time data collecting, and yeah. Before we doing MRE, we also uh, do the baseline and the indicators itself. But sometimes we as a NGO itself still struggling with the data openness from the government, the
Right.
central government or the local government,
Right.
because we need the data from the others for the others indicator, and
Yep.
yeah, we still advocating to the data openness to them, and sometimes it's still complicated with the bureaucracy and administrative stuff. Yeah,
Right.
that's
Okay.
from my
No,
experience. But so
that's good.
far,
Yep.
we when we using a survey CTO, we still face the some bias itself. The bias itself from the enumerator.
Okay.
Maybe they still confused how to assess what's going on in the field, or maybe yeah,
Mm,
the timing itself from the real
right.
time and the back time. Yeah, that's
Okay.
from
Right.
the group 3.
Yeah. No, thank you for sharing. It's challenging, isn't it? Yeah, data sharing with other sectors that feel like they own the data, even though it's collected from people, the public, so that can be a problem. It can depend on the permissions that have been given by the participating people. But if it's administrative aggregate data, it doesn't identify individuals. Usually that should be, I think, in my view, that should be made widely available and published, for groups like yours to access. So yeah, keep advocating. It's hard to change some of these things, but you just have to keep trying. But you have to find ways around. If you can't get that data, you have to maybe think about other ways of commissioning little pieces of work, being slightly clever in the ways you do it. It could be like getting people's views and opinions from street surveys, or I'm just trying to think of ways which colleagues of mine have sometimes gone about getting around where there's difficult access to data they need to inform whether something's working or not, or what people's opinions are, and they've tried some clever ways which are still ethical to do that, especially if you're very low resourced. Okay, we haven't got much time left, but we're out of time. But one more comment from one more group, but please very brief, and then we will have to shut down for the day. So was it group 4?
Yeah, I think group 4 managed to have a discussion, but not sure. Yep.
Okay, I'm from group
Oh, hi,
4.
Prita.
So
Yes.
yeah, my name is Prita, and we have discussions from Malaysia, if not mistaken. He said that he had a health awareness program, and they usually evaluate the program depending on the feedbacks of the consumers. And the second from Vietnam, she said that they do intervention through checklist. And the barrier that she had is when they enter the informations, the capacity of the red cap is a management system.
Yeah.
Like the capacity of the red cap is limited. So yeah, that's the barrier. As we from Indonesia, we usually monitor and evaluate the health program through like manually. So we hold a meeting, and we have set up indicators for the program, and the indicators usually like the the percentage scope of the program or the number of people get screened, something like that. But when it doesn't meet the expectation or the target, the learning mechanism is not well documented. So that's what we have as the problem.
Right. Okay. So that's a really good point. As I said, if you can do a sort of process evaluation, at least document what decisions were made and why at the time, that can help explain why you didn't get the results you sought to achieve. And sometimes in a program that's running, people change and the institutional knowledge is lost. A new person has to pick up the program, and unless that was documented, in early stages around why certain things were put in place, people don't always remember what that was. So that's why, documenting particularly the minutes of meetings where decisions are made and retaining those minutes so you can go back and have a look and understand. Even that's really simple, but it's very effective in a way of trying to improve a program. So all these things overlap with continuous quality improvement programs are very similar tools. But we do have some restrictions, like you've talked about data sharing, but also the capacity of the databases. That may be to do with the license and the limitations, because we use REDCap here all the time, and I've never had a problem with the size of the data, so I'm not quite sure what the issue is there, but it may be to do with the cost of whether it's the free version or another version. Look, those are all great contributions. Thanks for your engagement. It's been a long session, but I hope you have changed your behavior in some way as a result of our intervention, and you can evaluate your behavior change when you finish work today and reflect on what you've learned, whether there's been an improvement in your knowledge or what have you. I'm joking, but we use these tools all the time, intuitively and implicitly, often in our day-to-day lives, but we don't always think about them when we are involved in running projects or programs. So, and if we can communicate that to our decision makers and try and find ways that we can sometimes get more support for putting them in place. I'm going to close now because we're out of time. So I'm just going to close with a karakia, and then we will I'm just going to say this one here, which is tēnā ana o tātou, tēnei au ka mihi atu, mō te pai o tātou te no o tahi, me te atua o no korero, no rera, e aku rangatira, hoki pai atu ki o koutou tari, ki o koutou kainga, ki o koutou whānau, kati rā, tēnā koutou, tēnā koutou, tēnā koutou katoa. That means, again, thank you for your excellent meeting, for the high quality of discussion. May you return safely to your homes and your families. Farewell, and we'll see you next week.
See you next week, last week.
See you.
Thanks, everybody.
See you next week. Thank you very much.
Okay,
Thank you
bye.
so much. See you next week.
Pleasure.
See you next week.
See you.
Okay,
Bye.